So first of all, let's define my field. We study inflammation or pain in muscles, joints, or fibrous tissues in children. And this distinguishes us from, for example, orthopedists who primarily deal with skeletal and bone problems. The essence of this field remains the history and physical exam. And I'm going to accent that at all stages, particularly in diagnosis and determination of manifestations of the diseases. And I'm even going to start with an overview of how pediatric rheumatologists go about, in great general terms, the history and physical. So first of all, I'm going to talk in particular about several inflammatory conditions, and these are listed here: arthritis, vasculitis, lupus, dermatomyositis, and autoinflammatory disorders. And I'm going to leave out many, because even these big four, which are among the most common with which we deal, are still quite rare. And as you can see, these numbers represent per 100,000 patients per year presenting with these diseases. So by definition, everything we do is an orphan disease. But what we do is primarily what was done 300 years ago, as in this painting, which is that we examine patients, we talk to them, and we try to figure out what's going on. And towards that end, one of the most important things in the history is trying to determine the symptoms' timing, nature, and character. In particular, what makes it better or worse, when is it better or worse, and does it feel as if it is burning or sharp, constant, achy, etc. And this is most important with the bread and butter of pediatric rheumatology, which is the presentation of joint complaints. And there are four major classifications of these joint complaints, and they distinguish diagnoses on the basis of the timing of the symptoms. This is very useful because obviously in pediatrics it may be difficult to get information on the nature of the pain, but someone, if not the patient herself, then the family, is able to tell us when things seem to be the worst. And you can see that inflammatory disorders or arthritis tend to be worse in the morning, and mechanical disorders tend to be worse with use, and everything else tends to be constant. And this is an important point because, in fact, contrary to what one might believe, arthritis is not typically painful in children. We have no idea why. Obviously, adults are extremely uncomfortable when they have arthritis. Yet this study done by a medical student at the University of Oklahoma found that only 9% of children who presented with musculoskeletal pain actually had arthritis, and the rest had a variety of mechanical or somatic pain syndromes. So, believe it or not, pain is the strongest negative predictor of inflammatory disease in children. Inflammatory disease is, in fact, worse in the morning. There's usually morning stiffness. Symptoms tend to improve with activity, the so-called gelling phenomenon. If you sit down for a long time, you're stiff when you get up. And this is the sine qua non of arthritis, 30 minutes or more of stiffness when you wake up in the morning. And by the way, kids also don't like going swimming in the cold water because it has the same effect on the joints. This is diametrically opposite to the pattern of pain in mechanical disorders, which probably should be sent to orthopedists because they are more likely to involve injuries, bony problems, or other mechanical issues that can be dealt with by a surgeon. And so these tend to be worse after activity, hence the name. Runner's knee is worse when you run. They tend to be worse after a long day of activity, and as noted, they're due to overuse, sprains, various kinds of injuries. The third type of pain is the constant pain, but it may waken at night, and neither of the previous two types of pain should have done that. This doesn't change with activity, but anything that wakes a kid up at night because of pain is worrisome, and this may be due to infection, to trauma, or most worrisome, to tumor. The temporal pattern of neuropathic pain is quite similar. It is also constant, but in some ways it's worst at night when people are least distracted. So when they're lying in bed trying to fall asleep, that's when that achy, pulsating toe starts to really get to them. This doesn't change with activity, but it can be described as a burning or lancinating or shooting or electric quality. And there's what's called allodynia. If you have an abnormality of a deep nerve, then the cutaneous branches become hypersensitive, and even gentle touch of the overlying skin is very painful. This is important. If the skin is normal but very tender, it strongly suggests a neuropathic kind of problem. I have this slide because the last word on it is my favorite word in the English language. Non-organic pain, which nobody really likes to take care of because it's time-consuming, it's difficult, it's often frustrating, but nonetheless it often comes to rheumatology because we are usually happy to spend the time it takes to help our patients with this type of pain, even though it is frustrating. And so these people are present with not only complaints of pain, but pain that really disrupts their lives. We call it functional pain, but it's really dysfunctional pain. They can't go to school, or if in adults, they can't go to work, and they can't sleep. They tend to have multiple poorly defined somatic complaints. So, for example, a patient with fibromyalgia has 80% overlap with a patient with irritable bowel syndrome, another type of somatic pain disorder. And they often get to us after multiple physicians or consultations, and of course, that catastrophization. They will say it's not just pain, but it feels like an atom bomb that went off in the shin with neutrinos shooting up the spine, and so forth and so on. So after we've tried to nail down the patient's chief complaint with the history, then we move on to the physical exam. And while we're doing this, it's important to keep a couple of implicit assumptions in mind, primarily Occam's razor. That is to say that if we see a child who has a fever and a swollen knee, we assume that they go together and that one issue caused both problems. We have to at least acknowledge the fact that it is possible that it is two separate problems. And in fact, maybe he has a painful knee because there's a tumor in there, and maybe he has a fever because he has an intercurrent viral illness. So one should be aware of the assumptions one's making when going over the differential diagnosis. And in addition, when one constructs a differential diagnosis, one doesn't want to wind up with this catacomb of wires, but you try to think of the most restrictive type of differential you can come up with. It's intuitively obvious. But if you try to come up with a differential diagnosis for fever, you'll be at it for a long time. If you try to come up with a differential diagnosis for migratory joint pain, there's only 5 or 6 things in children that can do that. When we perform the physical exam, there are also a few key points, and this is true of any pediatric exam. First, the patient should be relaxed, so I like to have him run around or play or give him a lollipop. We like to proceed systematically, so if and when we do have to wake up in the middle of the night, our muscle memory takes over and we can do the exam. We have to look first and then touch, because our eyes are much more sensitive than our hands, and even mild asymmetries are notable to the eyes, but not necessarily to the sense of touch. And when we do range of motion, it is very important to do the extremes of range of motion. If one only does the mid-range, one will miss most pathology because it affects the extremes first. A child with arthritis of the elbow loses the last 5 degrees of extension long before she loses the midpoint of extension. And finally, don't be a wimp, which means we're pediatricians, we're gentle, we like to make the kids laugh. But if you squeeze every joint and everybody's laughing, nobody's learned anything. There has to be at least one point where the child gives a little bit of a yipe, and therefore you can compare the sensitivity at that point to the sensitivity at other points. And anywhere there are differences, there's more likely to be pathology. When one does the exam, of course, one has to be thorough, so we have to say again and again to disrobe the patient, even though people are uncomfortable, both the patient and the doctor. And one has to be complete and look at areas that one tends not to look, hence the reason for disrobing. Acral areas, the hands and feet, nail bed capillaries, for example, which we'll talk about later. The perineum one has to look at carefully because all sorts of rashes can occur in rheumatologic diseases. The scalp and the ears, sun-exposed areas, and last and certainly not least, all 65 joints. So having given this overview, we're now going to talk about the most common pediatric rheumatologic disease there is, and that's juvenile arthritis. And by definition, these children tend to present with swollen tender joints, with a limp or regression of milestones, with morning stiffness, and remember, not necessarily with pain, but it does tend to worsen with cold, with damp, or with humid weather. And this schematic on the right just shows the relative incidence of presentation for 300 children with juvenile arthritis. I'm going to talk about nomenclature in a moment, but I tend to speak of juvenile arthritis in general because it encompasses at least 3 different terms which have been used over the last 15 years. Old studies, like this one from Danita Sullivan, were done using the earlier definitions, and therefore it's hard to say whether we can just change the name for the modern equivalents. So it's called juvenile rheumatoid arthritis here, but the point is that girls are much more affected than boys with arthritis, and indeed with all autoimmune diseases. And so this is probably because a woman and a girl have a higher set point on their immune system, and therefore they have fewer infections, hence they live longer, but they do have more tendency for autoimmunity, an overreactive immune system because of this higher set point. So the general criteria for juvenile arthritis is a person under 16 years of age with at least 6 weeks of arthritis, and arthritis is defined as joint swelling or effusion or decreased range of motion, tenderness, pain of motion, or increased warmth. So this is to distinguish from arthralgias, because arthralgias may be pain, but they certainly don't have the same implications as a swollen, warm, and red joint. And one must exclude other causes of arthritis, for example, infections, tumors, etc., before we can make this diagnosis. In the clinical exam, as we've talked to in general, and now in particular, one has to look at all the joints, and we can tell a lot about the form of arthritis by the involvement, whether it's large joints, like this young man on the left who has swollen knees, small joints like these fingers with dactylitis in a little baby, or cervical or axial, which is neck involvement. And one can see here that there is some fusion of the cervical spine in this patient. In addition, there's tenosynovitis, which means the insertions of the tendons and ligaments into bones may be inflamed in conjunction with the inflammation of the joints. It's also important to remember that there are a lot of joints we don't usually think about, but they may be affected. And the most worrisome is the temporomandibular joint. And this is affected in at least a third of children with arthritis, often missed, very hard to diagnose, even by MRI. But what we have to do is examine very closely. There's usually a decrease in the range of motion when temporomandibular joint arthritis gets started. And there's also canting, which means there's this angulation of the jaw. If you just look at her smile, it's very hard to detect. But if you put a tongue blade in like this, it gives you points further apart, and therefore you can see these 2 points on a line, and one can see that this is canting up or angling up to her left. That means that probably the left temporomandibular joint has had arthritis and it has become hypoplastic because of the inflammation. Similarly, when a patient opens her mouth, there may be deviation of the joint. There's crepitance if you palpate as this opening, and then there's often tenderness, but that's nonspecific. As with any kind of arthralgic, crepitance can just be stress. It can be tooth grinding. It may not be arthritis. But those don't usually cause these asymmetries and these growth problems. So complications may occur in juvenile arthritis. They're mostly related to the joints, although rarely they may be more widespread. And the most common is a leg length discrepancy if there's an asymmetric involvement of the joints. The knee tends to grow faster when it's inflamed because of more blood, more oxygen, more nutrients. And it therefore may result in a significant difference in length. Therefore, it's important to control asymmetric arthritis, particularly in the legs, before it has such a chronic effect. Similarly, the joint is not used as much, so the muscles can atrophy within as little as 48 hours of some disuse, and one may get irreversible contractures, as this youngster is showing in the right knee. There may also be micrognathia and retrognathia, a small joint or a joint with the mandible pushed back because of inadequate growth. There can be growth arrest of other points, too. If there's systemic inflammation of significant degree, then even total height will be decreased during childhood. And rarely, the most severe form of arthritis with rheumatoid factor positivity may lead to rheumatoid nodules, pneumonitis, and even to vasculitis. So as I mentioned, there are different kinds of nomenclature. I almost didn't go into pediatric rheumatology because the lectures I used to hear focused on the different nomenclatures, and it wasn't very interesting. It still isn't very interesting, and this is sort of arbitrary. It's all clinically based. So I think until we know precisely the pathogenesis of these and can be precise in our use of the different categories, it's best to just understand that basically one either has pauciarthritis if one has fewer than 5 joints involved, polyarthritis if one has 5 or more joints involved, and systemic arthritis if one has fever and systemic features of inflammation in addition to the arthritis. So pauciarthritis is the most common. It makes up about half of the JRA cases. That was the nomenclature used till about 10 years ago. And we don't have studies really that can distinguish now between the different forms of arthritis because that's not done with the new nomenclature. Presumably, children with fewer than 5 joints still make up about half or more of the cases. And these are the kids who are particularly at risk for getting ocular inflammation as well, particularly if they are girls with a positive ANA. And the problem with this kind of inflammation is it doesn't cause symptoms. It doesn't cause redness of the eye or pain, and therefore children are not going to come to the attention of the doctors when they present with uveitis before arthritis, as occurs in 10% of cases of juvenile arthritis. It may smolder and cause severe ocular damage. If the children are not screened for uveitis after the diagnosis is made, the same thing can happen. And in fact, before it was recognized that there's such a high risk of developing uveitis if one has arthritis, at least 30% overall, then there used to be about a 25% incidence of blindness in at least one eye in children with arthritis as they were detected as having uveitis only after there was enough damage to become visibly intrusive both to the examiner and to the patient. The complications of this type of uveitis are synechiae, or asymmetries of the lens, sometimes of the cilia, sometimes because of fusion between tissues due to inflammation, cataracts, and band keratopathy, which is calcification over the visual portion of the eye in order, due to inflammation, interfering with vision. Here we see a hypopyon in the bottom. This is a collection of white cells at the bottom from severe inflammation. And once again, be very wary of this in girls with polyarthritis and a positive ANA. Polyarthritis primarily is a concern for the joints. And this involves more than five or more joints. It's about 30 to 40% of cases. And this is the type that can lead to crippling arthritis if not dealt with aggressively. About 10% of these patients have rheumatoid factor positive disease, which is like adult rheumatoid arthritis. It is symmetric, erosive, and inflammatory, and when it's rheumatoid factor positive, it's essentially the same as what happens in adults when they develop rheumatoid arthritis. The difference is only about 10% of children with polyarthritis have rheumatoid factor positivity, whereas adults it's about 80%. So there are clearly differences between juvenile and adult arthritis, but at least this one subtype is very similar. And you can see that they difference in the haplotype associations that may be seen, the classic DR4, DR1 in adult arthritis versus DPW3 in children. Rheumatoid factor, just to review briefly, is an autoantibody. It's seen in a variety of circulating immune complex diseases, but it's pathogenic only in arthritis, typically adult arthritis, and it can be a very poor prognostic sign for a severe form of arthritis, so we tend to be more aggressive more rapidly in children with this. But remember, it's not diagnostic because one can have serum sickness, subacute bacterial endocarditis, or a variety of other conditions that have circulating immune complexes which give a false positive rheumatoid factor test. The third and final large subtype of juvenile arthritis is systemic juvenile arthritis. This is arthritis with systemic symptoms such as fever, rash, lymph nodes diffusely, hepatosplenomegaly, and serositis, which may result in pericarditis and difficulty lying back to sleep, or pleuritis and difficulty taking a deep breath. And this is perhaps a different type of disease than the others. First of all, the gender discrepancy is far less. It's not the 2 or 3 to 1 that is typical of POSI and polyarthritis, but it's almost 1 to 1 boys to girls. And the type of genes that seem to be upregulated, here we have a gene expression profile of the blood of children with new onset untreated systemic juvenile arthritis, and the areas with red that are consistently seen across, these are the different patients going from left to right, and you can see that several of these genes are upregulated, the blue ones they're downregulated, and these tend to be related to certain cytokines, pro-inflammatory cytokines such as IL-1, IL-6, and IL-18, and in addition one may see some fluctuation of these cytokines spontaneously as the disease severity fluctuates. We don't see that typical picture in the other types of arthritis. The major complication in this disease, besides severe arthritis and severe inflammation, which may cause growth arrest and damage to the joints, is what's called macrophage activation syndrome. And this is one of the few potentially fatal complications in arthritis, so therefore important to make note of. It complicates about 5 to 10% of cases of systemic JIA, but very rarely in other forms of arthritis. It may be seen in lupus, it may be seen in Kawasaki disease, and in all cases, it's acutely life-threatening. It says here that the mortality is 10 to 20%, but without adequate recognition and therapy, the mortality rate is actually 50%. It's characterized by a cytokine storm with an explosion of several cytokines, including the pro-inflammatory cytokine TNF-alpha and interferon gamma. And it may be triggered by viruses, especially the herpes viruses, or certain drugs. And so, not surprisingly, this drug in particular, sulfasalazine, is verboten in systemic arthritis because it may trigger this severe reaction. This disease is characterized by fever, disseminated intravascular coagulopathy, elevated liver function tests with hepatosplenomegaly, elevated ferritin and triglycerides, and systemic effects of severe cytokine release with congestive heart failure, seizures, coma, renal failure, blood clots, and eventually potentially death. So that's important to keep in mind if a patient who has systemic arthritis and may have a waxing and waning fever or some arthritis suddenly develops a chronic fever, a rash, and does not seem to be responding to the typical therapies that have been used for the arthritis. So a word on management, and management is important in all aspects of rheumatology, because during my tenure as a rheumatologist, the field has changed dramatically. We used to have kids come to us in wheelchairs. Now we do not. This is due to the revolution in biologic response modifiers, or biologic drugs, and therefore it is very important that the disease be recognized early, that the child be made comfortable so that he or she does not learn to avoid activities. If you let a child have arthritis for several years, that child will learn to avoid sports, and it may be impossible to be reversed any time during her life. You must control the underlying inflammation, because this is an inherent evil. It causes disruption of growth. It increases the risk of malignancies and so forth. And one tries to maximize the functional status. And all of this goes hand in hand with the medications we use, which are aimed at preventing progression and joint destruction and allowing a child to grow up normally. So aggressive therapy is extremely important. And in the old days, we used to treat with medications that were symptomatic relief, but didn't accomplish much for the underlying disease, so the joints would continue to get damaged and the inflammation would persist. Now we have effective drugs that can control it, so it is extremely important that the child be diagnosed and be taken care of by someone who is familiar with these very complicated and potentially toxic medications. The data in adults is better than the data in children, but it is certainly true that if one treats children with new arthritis early, they will do better. And this is because most of the damage occurs within the first couple of years of disease in adults, and certainly in a linear fashion in children. So the sooner you control the disease, the less time there will be for damage. And not only that, but the medications seem to work earlier in the disease better than later in the disease. And that may have something to do with the immunologic drivers of arthritis, which may start with an antigen-driven process, but then may broaden to include non-antigen-driven processes, which would require greater immunosuppression to suppress. So we do use nonsteroidals, but we don't really use them consistently because we try to control symptoms with more effective and protective agents. But when one does use them, one should use them effectively. So, for example, we use longer-acting medications, not ibuprofen necessarily, but something like naproxen or meloxicam, which may be given once or twice daily, and cover throughout the day. Remember that they don't cause joint protection, and they don't alter the natural history of the disease, but in the short term, they may make the patient more comfortable. And they may have both GI toxicity, with which everybody is aware, but also rare cutaneous toxicity. And I'm not sure if you can see this, but there are these scratches and small red craters on the child's face. This is called pseudoporphyria, and this is a complication of some of the nonsteroidals with sun exposure. It may occur in up to 20% of kids who have fair skin, and it's important to avoid because it can really cause disfiguring scarring. Steroids we all know about. These have been the mainstay of treatment for arthritis. Fortunately, we're able now to taper off steroids quickly because we have alternative steroid-sparing agents which are very effective. But when they were first discovered 65 years ago, they were the miracle that everyone had been looking for. And stories of patients in the Mayo Clinic where Philip Hench worked when he unveiled corticosteroids talk about people who have been bedridden for years. They take their first dose of steroids and they're up and about for the first time. It was truly a miracle, and he won the Nobel Prize for Physiology or Medicine in 1950 for this miracle. Unfortunately, they next learned that chronic use is a disaster. It decreases growth in children, increases weight gain and osteopenia in adults, increases the risks of infections, so it may not be used chronically. As a bridge or as an emergency therapy, it's great, but long-term, it's toxic, and it doesn't prevent long-term damage. It doesn't prevent erosions, so we can't rely on that. Instead, we use disease-modifying drugs. Sulfasalazine is the mildest. It's not used very often, but it is the only one that is not immunosuppressive to any significant degree, and therefore, if the child has very mild disease, it might be a nice choice. It is, of course, herself a drug. One has to be careful. Antimalarials are not used very often in arthritis. We'll hear more about this later in lupus. But we usually go right to the antiproliferatives, methotrexate, or the cousin pyrimidine antagonist, leflunomide, which are very effective, in controlling erosive disease. So these are true disease-modifying agents which prevent erosions. When those don't work sufficiently, and now we often say those don't work completely because we really do try to achieve a full remission, then we use the biologic response modifiers, particularly anti-TNF agents such as etanercept, infliximab, and adalimumab, but various other classes of cytokine antagonists or receptor antagonists are also available, hence the need to be comfortable with a wide variety of immunologic agents with a wide variety of immunosuppressive effects. So when I was in training, this is what we were taught. 80% of children can expect to be rid of inflammation when they reach adulthood with arthritis. Why was this? It was because 80% of children stopped seeing their rheumatologists, their pediatric rheumatologists, when they reached adulthood. So out of sight, out of mind, they were assumed to be well. This is certainly not true. So this is the most recent good outcome study from 2002, so a while back, really before the era of the biologics. But you can see that the percentage of children in remission is not very good. So it goes from 6% when you have adult-like arthritis, rheumatoid factor positive disease, down to about 50% if you have pauci-articular disease. But it's always less than half of children are in full remission with no disease activity more than 10 years out. And I'd like to thank Dr. Peter Nigrovich for allowing me to borrow this slide of his. And we see in various other measures of outcomes that these diseases are not benign. And again, this is the most recent and the best, and you can see that the outcomes are dramatically different, but even this was with methotrexate and before the era of the biologics. So we assume that we are doing even better now, but we don't have those data. But you could see class 3 or class 4 means either wheelchair-ridden or unable to perform many normal functions. And this was as recently as 30 years ago, a quarter to a third of all patients after only 10 years. So terrible disease. Fortunately, we now have good drugs. Another way of looking at it is how often there's active disease. And here the interesting point is if you cut off medications, even today when we have such good medications, the disease comes back. So while we can control it and prevent damage, we cannot cure it. When patients are worried about taking these potentially dangerous medications indefinitely, I tell them that my goal is to try to keep the kids healthy so that when we do finally find a cure, they will be able to benefit from it optimally. So speaking of inability to cure, we're going to now move to systemic lupus erythematosus, where a remission rate of even 47% in pauci-arthritis looks good compared to what happens in children with lupus. And this, for fans of history, is a lupus erythematosus cell. This was the first biomarker discovered for lupus, and this is phagocytosis of an antibody-coated nucleus by a phagocytic cell. And this was discovered accidentally, but it was the initial test for lupus, and it led to the test we are more familiar with now, which is the anti-nuclear antibody test. So pediatric lupus is a small percentage of all lupus. It's about 20%. It most commonly starts during adolescence, and that goes with the fact that it's far more prevalent in women than men. So there are both genetic differences that cause an increased risk of lupus, that is the XX chromosomes, but also hormonal differences, and that's why the disease tends to present during or shortly after puberty. If you think your child has lupus before the age of 5, you're almost certainly wrong, so think again. It's case report literature. And lupus tends to be more severe in children than in arthritis, as we'll see in a few minutes. The incidence is not very high. It's 5 to 35 per 100,000 per year, and only about a fifth are men. So this is a true autoimmune disease. The higher titration of the women's immune system increases the risk. And there are ethnic associations too, as well as some genetic associations, but basically Caucasians are less involved than Asians or Hispanics, and African Americans have the highest incidence, with as many as 1 in 250 African American women of childbearing age potentially affected by lupus. These are the classification criteria, and as is true of all of our diseases, we do not have single blood tests that make the diagnosis. Hence, the importance of history and physical. And here you see a bunch of history and physical signs of lupus with only a few laboratory studies. If you recall, in juvenile arthritis, there were no laboratory studies included in the diagnostic criteria. So 3 of these have to do with rashes. 1 of them has to do with an enanthem in the mouth, ulcers. And then the rest are system involvement, so it's serositis, arthritis, kidneys, brain, and blood. And then the immunologic criteria the positive anti-double-stranded ANA or anti-Smith, and the positive ANA. And of course, these should be looked up if one is not sure. And in children, the presentation is typically with arthritis and a malar rash. And although they only have nephritis at the beginning about a third of the time, it rapidly goes up to 50% during the course. They're almost always ANA positive. It is very unlikely that a child has lupus if the ANA is negative, and almost as likely to not be lupus if the double-stranded DNA is negative. As you can see, the presentation and symptoms are different in children than adults, and the reason we say that a disease tends to be more severe in kids is this one right here. The major prognostic factor in lupus is the extent of renal involvement, and children get it more often than adults. The signs and symptoms during the disease course also prefer severity in a child, so not only more renal involvement, but more central nervous system involvement, which is also potentially fatal and another cause of the worst morbidity of children with lupus. So the dermatologic involvement is the one you'll see the first. This is a combination of a butterfly rash as well as some discoid lesions. The butterfly rash doesn't scar, but the discoid lesions do. One can rarely get bulli, one can get vasculitic lesions, and they tend to come out in the sun, so therefore sunscreen is important. And then a variety of agents. If it's only skin lupus, one can avoid the strong immunosuppressant agents. Oral ulcers are asymptomatic. You have to look in the child's mouth to see if they're there. They're typically on the palate. They don't scar, and they're typically asymptomatic. Renal involvement goes up to 66% of children during the course of the disease. And the most interesting fact is that early in the history, the first symptom is nocturia. The kids have a decrease in the concentrating ability of their tubules, and they tend to wake up at night to go to the bathroom. Other signs are, once you test the urine, hematuria and proteinuria, always look at those blood pressures in your kids, because that may be the only clue there is. And it's severe with diffuse proliferative glomerulonephritis, or class 3 or 4, which can result in renal failure in almost a half of all children. Again, far higher than in adults. CNS involvement affects 20 to 30% at least, but many more have headaches. 80 to 90% of children have headaches. We don't usually consider that evidence of parenchymal involvement of the brain, but it sometimes is associated with frank CNS involvement with lupus. And the manifestations are a bunch of effects on cerebration, as well as behavior, and then various more measurable effects, such as headaches with pseudotumor, transverse myelitis, which can result in permanent paralysis if not diagnosed, and peripheral neuropathies. And later on, these can lead to strokes or secondary infections. Arthritis is seen in about half of kids at presentation and 80% overall. It's non-erosive typically. It's more in the small joints. There's a lot of tendinitis as well. So it looks a little bit like polyarthritis, but much more tendinitis. And in the hips, they get up to 40% incidence of avascular necrosis, even without using steroids. There's often subclinical myositis. If you measure a CK, you might see it, but it's not usually clinically important, and the kids are not usually weak from this. The marker in lupus is the ANA, and it's a marker of autoantibody production. It may be due to abnormal B cells, which are secreting the antibodies. It may be driven by viruses like herpes viruses. It may be due to inadequate T cell surveillance. It may be due to abnormal clearance of immune complexes. There are mouse models for each of these, and each of them has clinical features of lupus. Similarly, patients have different types of symptoms, different patterns of symptoms, and probably different underlying genetic causes. There are also genetic variations in the immune response genes, and certainly environmental and even epigenetic effects that seem to lead to lupus. One of the more interesting papers in the last 10 or 12 years was this paper by Melissa Arbuckle in the New England Journal of Medicine in 2003, and she looked at Army recruits. The Army stored blood on these recruits when they joined the Army, and then they came to Dr. Arbuckle, they came to a rheumatologist about 5 years later, and there were more blood tests. So the early blood tests were compared to the late blood tests, and what this shows is that there's a gradual accrual of pathogenic autoantibodies. So the first autoantibody may be an anti-Rho antibody, but over time, when we'll get this whole panel of different autoantibodies, the anti-Smith and the anti-double-stranded DNA, most typical of lupus. So in other words, lupus evolves, and it may be mild initially, may be explosive, but over time it's likely to get worse if we don't treat it. The ANA is not diagnostic because it may be seen in a lot of things, and as we mentioned, the lupus erythematosus cell test is obsolete. It's not done anymore. The reason that an ANA is not diagnostic is it may be seen in a variety of other conditions. These are connective tissue diseases, and you can see that the percentage, while lower than in lupus, is still pretty high, and the titer is very similar, and the range is very similar. All we can say for sure is that if it is a very low titer, it's more likely not to be connective tissue disease, and a very high titer, say over 1 to 1,000, is likely to be an autoimmune disease. But we cannot rely only on the ANA for the diagnosis. And that's borne out by these two conflicting studies. One of them looked at children with an ANA greater than 1 to 20, and the large majority, about 3/4, had autoimmune diseases in this study from 1983. Then a pediatric rheumatologist looked in 1992 in Canada, and the result was precisely the opposite, that with a titer of 1 to 20 in 24 patients, none had autoimmune disease. So as with most of these dueling studies, the answer is somewhere in the middle, but the take-home is that we can't rely on just ANAs for diagnosis. Risk factors for morbidity and mortality is renal disease, 1, 2, and 3, and the more diffuse it is, and the more persistent it is, and the more severe it is, the worse it's going to be. Other things that can develop over time, pulmonary hypertension, chronic disease activity in general is a risk factor for infection, and certain races, particularly African Americans or socioeconomic status, those who don't have good access to health care, are also risk factors. And the causes of morbidity and mortality are most importantly infections. So early means at presentation. Once they are being cared for, infections is the #1 cause of mortality, and it's more common than all of the other causes put together. So be aware of a fever and an infection, or in a child on steroids, no fever and an infection. Very dangerous. But as the disease progresses, all of these things can lead to morbid and potentially fatal complications, whether renal failure, atherosclerosis, or pulmonary hypertension. So the last good study in lupus found that starting in 1960, when the ANA was first available and steroids were first being commonly used, and the 2-year mortality rate was 100%, to the 1980s, when the 2-year mortality rate went down to approximately 20%. We probably do better now, but we just don't have good studies to know for sure. I can say that while patients used to die early in my career, they really do not do so anymore, at least not during pediatrics. Now, therapy, again, sun avoidance, and then anything that can activate the immune system is going to make autoimmune diseases worse, so stress is not good. We tell people to have a heart-healthy lifestyle, which means diet, but also exercise, which both lowers the high cholesterol levels seen in lupus and helps relieve stress. And then not to be forgotten on those medications, which although many people would like to not take, are essential. And the goals are, with all of our diseases, optimize quality of life, maintain organ function, minimize medication toxicity, preserve longevity, and the holy grail to attain disease remission, much harder in lupus than in arthritis. The most important medication in lupus, and the drug that everyone with lupus should be on, maybe lifelong, is hydroxychloroquine. And that's because it is very benign. It may cause a retinopathy at doses above 7 milligrams per kilogram, but Q6 monthly screening by an ophthalmologist will detect it and allow the drug to be withdrawn before irreversible retinal changes occur. It can also cause dyspigmentation and a not very pleasant gray hue to the skin, but it prolongs remissions and progression. And this is if people have partial lupus, for example, a positive ANA, thrombocytopenia and arthritis, but not meeting 4 criteria for the diagnosis. It will prevent it often from going on to full lupus, which improves the prognosis immeasurably. And once a patient is in remission, it will prolong the remission. It also has mild anti-arthritic effects. So the bottom line, once again, anyone with lupus that has not been cured or has gone into full medication-free remission should stay on Plaquenil, hydroxychloroquine. And in a Canadian study, even those who were in a full medication-free remission, apart from Plaquenil, had at least twice a high chance of flaring in the next year if the Plaquenil was stopped. So the agents that we use to try to get this terrible disease under control are potent immunosuppressive agents. And this is a review in 2014 that looked at the different chances of doing well over time. And it shows that azathioprine and mycophenolate, the newer agents, are actually more effective long-term in prolonging longevity and decreasing mortality. Whereas cyclophosphamide, which has been the mainstay of our treatment, while it is very effective in controlling disease, the immunosuppression leads to secondary malignancies and infections more commonly, and so should generally be avoided unless it is impossible to do so. So these medications are all, when they are primary disease-modifying agents in lupus, they immunosuppress. Cyclophosphamide for sure, and perhaps azathioprine can cause infertility. All of these immunosuppressive agents can cause secondary malignancies, and believe it or not, kids, especially girls in high school, are bothered more by this than any of this, because these are sort of theoretical and in the future. This is the here and now. And this may be enough to be non-compliant with medication. So we have to not impose our own values on what is or is not important in terms of toxicities of these medications. I'm going to next go to juvenile dermatomyositis, not because it's common. It's about 3 per million per year in North America, and not because any of you are likely to see it in practice, since it's so rare. But it is a proof of a concept that if we treat these diseases early enough, we may actually be able to cure them. So this is a picture of nail bed capillaries. And juvenile dermatomyositis is one of 4 diseases called microangiopathic diseases, which affect the small blood vessels. These are nail bed capillaries. And you can see this is slightly enlarged as opposed to here where they are regular and very even. This may be seen in Raynaud's or may be seen in early connective tissue disease. This is more severe tortuosity and some dropout. And this is the most severe of all here, with not only tortuosity and dropout, but some hemorrhaging from the capillaries in the nail beds. So these kinds of changes are seen in dermatomyositis and lupus, as well as scleroderma and mixed connective tissue disease. You can buy a fancy light to magnify the nail bed capillaries and look at them, or you can just use an ophthalmoscope at a +40 with some surgery lube on top to change the focal point, and you can see this. And this is virtually 100% accurate. If you see this, this child has one of the microangiopathic diseases. So dermatomyositis presents with a rash, as all of our diseases tend to do, Gottron's papules, and here we see the heliotrope rash, a sun-loving rash over the eyelids. It presents with weakness and elevated enzymes, as well as laboratory evidence of other types of myositis or MRI evidence. Traditional therapy has always been high-dose steroids, and 30% of patients would get calcinosis. This is mild calcinosis. It can cover the entire skeleton and be immobilizing if this disease is not taken care of. And it is associated with chronic active disease. So what we have looked at and other groups have looked at is early aggressive therapy. And for reasons that we don't really understand, it is more important and more effective in dermatomyositis than any other autoimmune disease. And in fact, we can cure this with early aggressive therapy. So we start with oral prednisone and intravenous methylprednisolone if the muscle enzymes are high. And within a month, if the muscle enzymes have not normalized, we add methotrexate. And then we may add Plaquenil for the rash. Here again, it's good for rashes. And after 2 months of methotrexate, if the child is still not significantly or completely improved, we add second-line agents. The interesting thing is also that it may not matter which second-line agent we use. Very many of them may work. We prefer cyclosporin, but one can use tacrolimus, one can use azathioprine, one can use mycophenolate mofetil. So many different possibilities may be added, but the point is not to let it smolder. So we looked at 38 children with a mean age of 7.3 years and slightly increased percentage of females, but overall it's closer to 50-50. Diagnosis was typical of rheumatologic diseases. It took a long time to come to attention and diagnosis, about 6 months in this case. And mean follow-up of these patients was 5 years. And what you see here is that about 80% had a complete clinical response, and about 65% had a clinical remission. But it ceased to be a clinical remission because they were tapered off their medications, and these people did not relapse over the next 3 years. This is unique and exciting, and this is the work that is trying to be duplicated in other diseases. So now there are early aggressive therapy trials in arthritis, in lupus, and various other things. Again, for reasons we don't understand, we can reset the immune system to stop causing the disease in children with arthritis, children with dermatomyositis, but not in those other diseases just yet. And this is the survival curve showing the percentage of responders with a complete clinical remission on the top or a clinical remission on the bottom. Here you see the side effects of this aggressive therapy. We used a lot of steroids initially, so there were stress fractures, hypertension, and some infections, but nothing life-threatening, no opportunistic infections because we're not using potent immunosuppressive agents. And we only had 6 patients out of those 43 with calcinosis. 4 of them resolved, and 2 of them were superficial and persistent. And this is very different than the historical controls. So at the same time as we were doing these studies, these 2 were published, and they showed calcinosis rates, one at another institution in Boston, so it's not due to different populations or different environment, one at the other side of the country. But basically, these are 25 to 35% incidence of calcinosis, often not only persistent, but diffuse, whereas we had some mild calcinosis in a small number, and more than half of them resolved completely, leaving us with less than 5% incidence of calcinosis. So calcinosis was associated with not necessarily the type of therapy or the severity of the disease, but rather it was associated with a longer time to starting the therapy and a longer time to normalization of muscle enzymes, i.e., early aggressive therapy in dermatomyositis can be curative, and we think and hope in the future we will be able to show the same thing in other rheumatologic diseases. So these patients had full remissions. They remitted relatively rapidly within 2 years, and apart from side effects of the steroids, they didn't have serious problems. So we're down to the final 2 areas of this talk. And so this is vasculitis. Vasculitis is a very rare disease, so we're going to focus on the 2 most common vascular diseases, which also happen to be pediatric diseases. So first of all, the prevalence is only 1 to 6% of everybody who comes to rheumatologic clinics, and the incidence is very, very low for the classic systemic vascular disease, whereas Kawasaki disease and HSP are relatively prevalent, at least as prevalent as lupus and close to the prevalence of arthritis. Therefore, we will focus on these. But generally, the manifestations of vasculitis depend on the size of vessel that is involved. And briefly, to stay on our focus of clinical important points, so large artery disease, such as Takayasu arteritis involving the aortic arch and large vessels that come off, such as obstruction here of the subclavian, leads to systemic inflammation measurable on lab tests and fever, constitutional symptoms such as malaise and anorexia, and then vascular insufficiency as large vessels become narrowed or occluded and inadequate blood gets to the muscles to allow them to function normally. So one gets pain with use, claudication, one gets hypertension if it involves the kidneys, abdominal pain if it involves the abdominal vessels, chest pain if it's the coronary arteries, and neurologic symptoms if it's the carotids. Small artery disease involves muscular vessels, but smaller ones, and so these are most common in the skin, in the kidney, and in the lungs. So the classic disease is polyarteritis nodosum, and these are the saccular aneurysms that occur in PAN, and it is in the kidney. Venulitis is what HSP is, and this is involvement of the capillaries or the veins, and this primarily involves the skin. But again, large numbers of veins, small veins and capillaries are in the GI tract and in the lungs, so one may get pulmonary hemorrhage or one may get GI upset and abdominal pain in these conditions. And the classification criteria change every few years, as they do in all of these diseases, because again, we don't have great biomarkers for these conditions, and we don't have lab tests to prove which one you have. There's overlap also. But basically, we distinguish on the basis of size, and the ones that affect children are the Kawasaki disease in medial-sized vessel and HSP in the small vessels. So these are just an overview of the different kinds of vasculitis that can affect people. This one doesn't ever affect children. We don't know exactly why. and by definition it happens only in people over 40. All of the others may affect children, but the average age, except for Kawasaki and HSP, are high enough, and the incidence is low enough that we will not talk about them. HSP is dependent on palpable purpura, and when the adults diagnose it, they diagnose it primarily in people under the age of 20, since it's so rare in adults, the sort of mirror image of giant cell arteritis. They have abdominal pain, which is nicely called bowel angina, and if you biopsy, which you shouldn't have to do, there will be granulocytes on the walls of the vessels, whether in the skin or in the kidneys or in the GI tract. Other clinical manifestations include scrotal edema. This is useful because not that many conditions involve the scrotum in children, and the most worrisome is vasculitis. Both Kawasaki disease and HSP, as well as PAN, may cause significant involvement of the scrotum. There may be CNS involvement, including seizures and strokes and headache, and pulmonary involvement, but usually these are less important than the classic clinical manifestations, which are rash, GI involvement, and arthritis and arthralgia. And then, although not as common and not as severe usually in children, but more severe in adults, the kidneys are the determinant of long-term prognosis. We'll switch now to Kawasaki disease, another of the favorite diseases I have, because, again, we can cure this one as well. And again, we're not sure why we can do it, but it's nice to be able to do it. So everyone knows the characteristic signs. In addition to fever, there is mucocutaneous inflammation, and 4 or 5 of these in addition to the fever. And this is the average day of illness, with day 0 being the start of the fever, on which the different manifestations occur. But one must never preclude the diagnosis simply because the order is backwards. The fever is hectic. It responds irregularly or incompletely to antipyretics, and it will go on for an average of at least 12 days without IVIG treatment. The lymphadenopathy is localized. It may be absent in up to at least half of patients, especially the babies, but if you have diffuse lymphadenopathy, it's more commonly seen in viral illnesses rather than Kawasaki disease. And other manifestation of reticular endothelial cell involvement, like the spleen, do not occur in Kawasaki disease. The ocular involvement is this limbal sparing conjunctivitis. So you see these bright red injected vessels with sparing along the margins of the conjunctivae. And it's more visible in the bulbar rather than the tarsal conjunctivae. And if you are not sure if a child has Kawasaki disease, often it's helpful to get a slit lamp exam, because up to 3/4 of children during the first week of the illness will have uveitis detectable on slit lamp exam, and many of the mimics of Kawasaki disease do not cause uveitis. So the characteristic finding in the mouth is the strawberry tongue. This has to do with exfoliation of the small papillae, and the large papillae become prominent, whereas the exfoliated areas become red and raw. They don't often get discrete oral lesions, and tonsillar exudate is also more suggestive of an infection than of Kawasaki disease. The rash can look like almost anything. It's primarily on the body, but may rarely involve the face, and it's 2/3 of the time it begins in the perineum, and it desquamates within 2 days of onset of disease. These children get dorsal swelling of the hand, as well as erythema of the palms and soles, and after about 10 days on average, the skin starts to peel in these large sheets from the tips of the fingers, called periungual desquamation, different than, for example, strep infections, where they're sort of flaking, but not these large flakes coming off. And later on, one gets linear lines on the nails. These are just signs of severe inflammation. They're nonspecific, and they're also not helpful in the diagnosis, because you won't see them for several weeks after the acute illness, and the child has to be treated before then, or one will develop an aneurysm like this. Myocardial involvement is ubiquitous. Much as in rheumatic fever, one seldom gets other parts of the heart involved. In Kawasaki disease, the coronary arteries. In rheumatic fever, the valves. One rarely gets those involved without myocarditis. So these kids have tachycardia. They often have an S3 gallop, although the heart's racing so fast it may be hard to hear. If we don't treat, 20 to 25% have aneurysms. Many more will have slight dilatation, not reaching the full definition of an aneurysm, which is at least 4 millimeters of diameter, and a mortality rate of 1% or more. Laboratory findings are helpful, but again, as is the story in rheumatologic diseases, not diagnostic. They are inflamed. They may have some urethritis, but that is in the urethra, so if you try to catheterize the child to look at the urine, you'll miss these findings. They're typically anemic even at presentation, which means something has been smoldering for a while when they present, and they usually have abnormality in liver function tests as well. There may be a variety of rare other complications, from irritability and lethargy to arthritis in about a third. This is non-erosive, but it can be extremely uncomfortable. It responds, but only partially, to intravenous immunoglobulin. And these children may also have hydrops of the gallbladder, so they may have a mass in the right upper quadrant, which is tender. And as we mentioned, they have hepatitis. So the vessels that are involved are not only the coronary arteries, although those are the most important and the most common, but any large muscular artery, especially those that are transition places, may be affected. And so children may develop axillary aneurysms with pulsatile masses later on in the course if the disease was not fully controlled. Treatment includes aspirin, but it has no effects on the most important outcome measure, which is the heart, and absorption and binding are erratic and may be potentially toxic, especially if a child has been exposed to varicella or varicella vaccine or influenza, when there's an increased risk of developing Reye's syndrome, even today, when you give them aspirin. So you don't have to use aspirin, but what you do have to use is IVIG. And this table nicely shows that the incidence of aneurysms in children with Kawasaki disease is not dependent on the aspirin, but is dependent on whether you got IVIG. Otherwise, the incidence is consistent, and it depends only on whether or not you got IVIG here or did not get it here. And in both cases, aspirin was given in equivalent doses. So we see here aspirin high dose, aspirin low dose doesn't change the incidence of aneurysms. So IVIG is miraculous. It's the single most cost-effective therapy in pediatrics after antibiotics for documented infections and immunizations, and it should be used in anyone with suspected Kawasaki disease. There is an algorithm for partial Kawasaki disease, which allows a lot of children who don't technically meet criteria to be identified as having Kawasaki disease and deserving of therapy, and this is available in reviews in 2004 in Circulation and in Pediatrics. Last but not least, the newest member of the pediatric rheumatology family is the autoinflammatory disorders. You may know them better as things like familial Mediterranean fever or TRAPS, but basically these are spontaneous or inappropriate activation of inflammation in the absence of a specific antigen or a specific antibody or autoantibody response. And these are some of the many diseases that have been identified. And this year alone, 2 new diseases in this category have been featured in articles in the New England Journal of Medicine, one of them a pulmonary vasculitis, the other a cerebral vasculitis. So more and more of these family members are being discovered. They are still uncommon. They are heritable because they are caused by single gene mutations, and therefore we can, in some cases like familial Mediterranean fever, make a genetic diagnosis, not something we can do in our other diseases. Typically, since they are genetic, they are also congenital, and they tend to present in childhood. And they have a variety of typical clinical manifestations. In other words, when one has unbridled inflammation due to these genetic mutations, one gets rash, arthritis, and serositis, as well as fever and systemic inflammation. And these are other manifestations that may be seen in difference of them. You can have different kinds of rashes. You may occasionally have nephritis. You usually have serositis. You may have inflammation of the bone ends, and you may have GI involvement. So the most important thing to remember is they have fever, they have inflammation, and they usually have a rash. And if there's a family history or this is persistent from an early age, think of these conditions. Laboratory disorders show early on increased acute phase reactants, later on an increased risk of amyloidosis, and this is one of the newer members of the family called DIRA, which is deficiency of the IL-1 receptor antagonist, and it causes severe periostitis and inflammation. But inflammation is manifested by polys at the sites of inflammation, and steroids may be helpful, but biologic agents are curative. Periodic fever syndromes are due to dysregulation of the innate immune system, and this aberration occurs through activation of antigen-independent inflammatory cells, including these as well as inflammatory cytokines, such as these. Some overlap with JIA, and as I mentioned, it may be that systemic JIA is actually an autoinflammatory disease, although we don't have any evidence that it's a monogenic form, and therefore it would have to be polygenic, and so far we're not able to identify such conditions. So the common themes of these autoinflammatory disorders is that they are due to aberrations in the innate immunity, that there's an inappropriate host pathogen response. So for example, in HIDS, Typically, if you give an immunization, it incites a lot of inflammation, and they get these very high fevers, rashes, and these may be the kids who seize also after certain vaccines. Whereas if they get colds, they may trigger other forms of autoinflammatory diseases. And this is, again, a list of the different types that you may encounter. Far and away, the most common is TRAPS, which is here, and we think it's autoinflammatory, even though it goes away by the age of 5, which would be hard to understand in a genetic disease because it responds to IL-1 blockade. Otherwise, the most common in the US and worldwide is FMF. These are in smaller populations, typically from Northern Europe and Holland. These are more from Ireland and Northern Europe, and it used to be called familial Hibernian fever. And this is a family of other diseases, all of which respond to IL-1 blockade. So I'm going to leave out what the specific mutations are, but again, this is unique in the field of rheumatology that there are monogenic causes of all of these periodic fever syndromes. And the rashes may vary, but it is generally true that they get various types of rashes. And while this may look at hives, it doesn't behave like hives. While this may look like HSP, it's on the palms, it's not behaving like HSP. And they are various degrees of severity. There are mild ones like Hibernian fever or HIDS, hyper IgD syndrome. And then there are the fatal diseases, if not treated early in life, called NOMAD or SINCA. So PFAPA you've all seen. Basically, it's 3 episodes of fever more than 3 weeks apart, lasting less than 5 days. They may get lymphadenopathy, pharyngitis, or aphthous ulcers. They are completely normal and growing normal between episodes. And if you measure them during episodes, they have elevated acute phase reactants and white blood cells. Between the episodes, they have normal blood tests. And you have to exclude such things as cyclic neutropenia, inflammatory bowel disease, or leukemia. But this is the most common thing you will see in your practice. These are relatively hard to diagnose, but basically if you follow the pattern and they repeatedly don't have evidence of infection of recurrent fevers every 3 to 6 weeks, start thinking about PFAPA. And just to show that this is probably an autoinflammatory disease, here again you have the heat maps with the gene expressions, and you see that PFAPA in a flare has certain characteristic upregulation of various genes. When they're quiescent, they don't have these. These are the aphthous ulcers that may be seen in this disease. I'm going to move a little bit quickly now, but these are the different manifestations. Although there are probably genetic causes of this as well as the others, the manifestations depend on the background gene makeup of the patient, and therefore there's a great variety of how they may present. Familial Mediterranean fever primarily has inflammation in the lungs, in the heart, in the kidneys, and in the joints, as well as on the skin. And this is obviously more typical of patients in the Mediterranean basin. These are the different diseases and their characteristics. Too much to look at right here, but notice that most of these are treated primarily with anti-IL-1, but TRAPS, which is a TNF receptor abnormality, is treated with anti-TNF. So you should suspect it and get it to someone who can use these biologic agents. And this family is increasing, as I said, and if I don't make this slide up again every 6 months, it becomes obsolete. So to summarize what you've heard today in relatively rapid fire time, we have to keep the long-term perspective in rheumatology. We know that these diseases can have very severe effects on growth, development, and activity levels, and therefore when we calculate the risk and benefit ratio of medications, we can't just take the short-term into account, but nor can we ignore the patient's concerns. And if we give them something that causes alopecia and they won't take it, we're not doing them a favor. Medications may have unique toxicities in children, but in general, children tolerate medicines better than adults because they have fewer comorbidities, less deteriorations over time than adults typically have. And our mantra is to say that we err on the side of aggressiveness. We will use higher and more complicated medications, but we still have to be careful because although we don't rely only on first do no harm, we must still take that into account. So if you have a differential diagnosis that is dangerous, maybe an infection, maybe a severe systemic rheumatologic disease, or if the patients or referring physician are very anxious, you may want to refer these people urgently either to a rheumatologist or, if not available, to an emergency room. Non-emergent, you can send them over a longer period of time if it's not life-threatening, but you don't want it to go on too long because it's really the early aggressive therapy that changes the quality of life. And if the condition doesn't act as you expect based on your working diagnosis, or if the child is unexpectedly debilitated by the diagnosis of the disease, then you might want to send for a referral. The bottom line is basically what Dr. William Osler said more than 100 years ago. The key to a long life is acquiring a chronic disease and taking good care of it. And what I take this to mean is that children who have arthritis have to exercise, they have to sleep, they have to avoid infection, and they have to eat well, or they're going to have more debilitating disease. So they don't abuse their bodies, and therefore they don't pay for the abuse all at once when they reach their 40s, but they can take care of themselves throughout their lives. So it's a great field. We can help our patients, and we need you